With that, I'm thrilled to introduce today's speaker, my dear friend, Dr. Alan Power. Dr. Power is a board-certified internist, geriatrician, and Schlegel Chair in Aging and Dementia Innovation at Schlegel University Waterloo Research Institute for Aging. He's also clinical associate professor of medicine at the University of Rochester in New York and fellow of the American College of Physicians, American Society for Internal Medicine, and an international educator on transformational models of care for older adults, particularly those living with changing cognitive abilities. I am pleased and honored to hand it over to Dr. Power to share his work with us. Thank you, everyone.
Thank you so much, Bahar. I appreciate your warm introduction. Thanks to GERIS and the Regional Geriatric Program for hosting this, and Bahar, to you for moderating. And also in the chat, we have Phyllis Fair, who's joining us, a dear friend of mine, who is living with a diagnosis of Alzheimer's and is an advocate and educator. And I'm hoping maybe when we get to the end and have a discussion that she may have some perspectives to share as well. In Rochester, New York, I'm also on traditional Haudenosaunee land, the Seneca Nation of the Iroquois League. And so I have some connections with you there as well. You know, a medical degree, what I'm going to talk about is rethinking dementia. And this is something that everybody on the call can do. So I'm hoping it'll be an empowering message. Just disclosures, it might not surprise you that the person who wrote a book called Dementia Beyond Drugs doesn't have a lot of financial sponsors for his talks. I do have a small knowledge mobilization grant to develop toolkits for the approach that I'm going to talk about. No other conflicts of interest. So what does rethinking dementia mean? Well, I'm not inventing anything new. We don't invent anything new, and we don't deny that there is true brain disease or injury. But we're looking at the world through other eyes. We're trying to expand our view beyond the narrow structures and the narrow rules and the biomedical approaches. We're also emphasizing the importance of learning from people who are living with the diagnosis and trying to appreciate each person's unique perspective. And in doing so, we not only find new solutions for living, but we also will have insights that may challenge many long-held views about dementia. So you're going to hear a few of those challenges today. Just very quickly jumping ahead, the biomedical model of dementia looks like a lot of these things. These are things you see in instructional courses and diagrams and adverts. You see plaques and tangles in the brain for Alzheimer's. You see scans showing the atrophy of the brain. You see that graphic I don't particularly like, which shows the tree with all the leaves flying away as if the person's disappearing. You see that sort of staging system, which I also am not crazy about, that kind of shows an escalator that goes on a steady course from normal to death, really focusing on the decline and the inability. So none of those is incorrect, but it's the focus on those things that can be a problem. And when you focus too much on the biomedical aspects of loss, aspects of inability, decline, you often have unintended fallout for people living with the diagnosis and for those who support them. And these are just a few examples of some of the fallout from a narrow biomedical view. The myths and stigmas around dementia are already out there. They're very prevalent in society. And when you only see dementia from the standpoint of disease and decline, that actually makes those myths and stigmas more powerful. And I've actually seen, I think Canada does a very good job, but I've seen other Alzheimer's societies who actually have increased the stigmas of dementia in trying to raise funds. And whether it's intentional or not, it certainly has negative fallout for the people who live with the diagnosis. We talk about dementia care. We tend to homogenize people as if it's all one thing, when we know that there are over 100 different causes and each person experiences those brain changes in a very unique way. Because we only see the biomedical disease when we're trying to help people to experience well-being, we tend to look to pills. And if we're told that antipsychotics are bad, then we say, okay, well, what pill can we use then? An interesting side note is that I had a conversation with somebody from the Inspector General Office in the United States, and they did a study of our antipsychotic reduction in long-term care homes in the US over the past 10 years. And they found that there was about a 33% reduction overall in the use of antipsychotics, but there was an exactly matched increase in other psychotropic medications, the anticonvulsants like Depakote and benzodiazepines as well. So we weren't really doing anybody a favor. We were just putting them on drugs that the government wasn't counting. And that shows that we just can't seem to figure out what we can do besides using a pill. We tend to disempower people early. When we see them from the standpoint of inability, we take things away much sooner than they should be, or we don't work with people to provide accommodations. And lastly, there's that abbreviation BPSD, which stands for Behavioral and Psychological Symptoms of Dementia. This has become the dominant framework for viewing people's words and actions. And I'm going to try to convince you briefly today to throw that out. And I'll be doing a little bit more with that tomorrow at the public lecture as well when we have a bit more space. So my new model is inspired by the people I consider the true experts. These are people who live with the diagnosis. You can see Phyllis there on the left second row. These are the people who have taught me as much as I've learned from any books or any medical professors. My greatest teacher was the late Dr. Richard Taylor in the upper left-hand corner, who lived with Alzheimer's for 15 years and then died about 10 years ago due to cancer. But we traveled together, made videos, gave talks, and it was just a wonderful and greatly educational experience for me. The embarrassing thing I have to admit is that not only have I learned from all of these people who are quite capable of speaking and writing books and talking about their experiences, but it embarrassed me to realize that I had many other teachers I took care of for many years who were more, let's say, advanced with their symptoms, who maybe I didn't understand were also very important teachers that I needed to pay more attention to. And so I'm going to suggest that to all of you before you get to my advanced age, that you learn that you're being taught by people every day, no matter what their diagnosis or what sort of stage they've been described as having. So the new approach, and the new approach is now almost 15 years old, but what I've been developing and evolving over the years has three components. The first one, and the first thing I did when I was trying to write a book about thinking about dementia differently, was I redefined dementia for myself. The second was not focusing primarily on disease, but focusing primarily on well-being. And the third is creating operational shifts in the care system to accommodate the new approach. And I'm going to unpack those briefly for you. When I wanted to define dementia, I realized that all that biomedical terminology and all that view was keeping my focus very narrow as a medical doctor too. And if I wanted to see the whole person, I needed a diagnosis that got away from that, got away from the narrow view, got away from the judgment, got away from the focus on decline. And so I worked with that, and I came up with a very simple definition nearly 20 years ago now. And this is the definition. Dementia is a shift in the way people experience the world around them. And I think you'll agree it's true. You might think it's a bit vague. It certainly wouldn't help people find a new drug. But no matter what kind of dementia you have, no matter how advanced your symptoms are, everybody in the world who has dementia, we can say, has had a shift in the way they experience, the way they perceive the world around them. We can also say that that's happened to all of us as we go through life and have different experiences. And the nice thing about this is this connects us in a way. We can begin to think about our own changing thinking and our own changing perspectives and say, okay, maybe it happened a bit more drastically for this person, but this is a way to connect us to that experience of changing mindsets. And I think that most definitions of dementia don't connect us, they separate us. They put people in a box and say they're different, they're not like us, they have a disease. And that doesn't really help us find new solutions. When I took that fuzzy, kind of flaky definition, I went down a different road than I had been for years. And one of the first things was meeting Richard Taylor, now about 16 years ago, and having him say the keynote, I am not dying of a fatal disease. I'm living with a chronic disability. And that was a real mind-blown moment, because he changed the focus from dying to living, from fatal disease to chronic disability. And when I began thinking about changing abilities, I began thinking about physical disabilities, and I began thinking about wheelchair ramps. If somebody wanted to get into a building and they only had 10 stairs, obviously in a wheelchair, they wouldn't be able to access the building and its services. But we build ramps, we build accommodations for people that can't use stairs like the rest of us do. And it occurred to me that with dementia, whether you live at home or whether you live in a long-term care home, we are not building cognitive accommodations. We're not building ramps for people with dementia. We're asking people whose brains are changing to live in a world that's defined by our view of the world, our rhythms, our schedules, our staffing needs, and we ask them to fit. And if they don't, we diagnose behavior problems. Sorry, I have a leaf blower outside. I hope that's not bothering you too much. It would be like going to the guy in the wheelchair and saying, we want you to walk up the steps because that's what we do. And we lift him out of the chair. And if he falls down on the steps and gets upset and yells at us, saying he had a behavior problem and giving him some Seroquel. Now, I know that that sounds ridiculous, but that's exactly what we're doing for people living with dementia. So we need to continue to help people to live well, to grow, to accept that they're not who they were as far as their abilities, but they have what my friend Jim Mann from Vancouver calls a new normal. And if we can't cure dementia, what are those universal human needs we should be meeting? It led me to challenge the stress. It led me to challenge a lot of our care practices. And it also, interestingly, reshifts expertise. When you define expertise, think about how we define dementia traditionally with these very complex changes in a complex brain. The brain is such a complex organ that it's hard for anyone to understand what's going on in there. And so the subject matter experts become the specialist physicians, neurologists, and psychiatrists. So if you are caring for somebody who, for example, doesn't want to take a shower, what do we do when it becomes a real challenge? We pick up the phone and we call a doctor because they're the ones that have been posed as experts. And I'll tell you something, I went to medical school and I never learned how to give anybody a shower. I'm not an expert in personal care. The PSWs and other people that do this are the experts in personal care. If you redefine dementia as a shift in the way people experience the world around them, instead of biomedical brain disease, who are the experts now? The experts are the person living with the diagnosis and those people closest to that person. So that may be family members, it may be primary hands-on care partners. And so this kind of flips the pyramid of hierarchy as far as who should be called in for day-to-day challenges. Now, there's a role for doctors. You need us, you need our diagnoses, our medications. But when it comes to a daily activity like a shower, you don't need the medical person at the table. You need the people that know that person and can understand how they need to be supported in the best way possible. The second leg of the stool was a focus on well-being. There are many, many different views of well-being. I chose one framework to work from, and it's the one I've used for the majority of my work over the past 20 years. This came from a white paper that was sponsored by the Eden Alternative, which is a long-term care and aging culture change organization. And they came up with what they thought all human beings need, regardless of nationality, ethnicity, faith tradition, age, or whether people live with a diagnosis or not. And I reordered them, and that order is identity, connectedness, security, autonomy, meaning, growth, and joy. And what I did for my second book was I decided just to take that framework and to apply each of those domains to the experience of dementia. What is it? How is it challenged by dementia? How is it challenged by our care practices? And how can we begin to restore these? And as I wrote this book, which I thought would be just a short little addendum to my first book and turned out to be much longer, I discovered a lot of things I hadn't discovered before. I raised a lot more challenges, and I realized that this is not just an important thing. In my mind, this is the important thing, and I'll explain why as we go along. The third one, and it's really important, particularly in organizations like long-term care homes or hospitals, and that's operational shifts. If you have a new approach, a new way of thinking, a new way of working, in order for that to happen, you need to change the daily processes, patterns, and routines to support new views of dementia and to maximize person and relationship centeredness. So some examples might be dedicated team assignments instead of rotating staff, flexible wake-up times or meal times, more individualized activities, following resident rhythms for rest and activity, et cetera, et cetera. And there are also parallels to this for people who provide care in the home environment. But without these shifts, you can educate until you're blue in the face and you're not going to see any change. And this is what I learned in working with culture change organizations like Eden, like the Pioneer Network, the Greenhouse Project, and others that I've worked with over the years. There are also three big shifts in thinking. The first one is rejecting that BPSD view of what distress is and other personal expressions. The second is really focusing on well-being, even when we're trying to solve a so-called problem. And the third one, which is another one we're not often taught, is to work with this proactively and not reactively. So let's unpack these, starting with my favorite up here on top. And I'm going to ask some challenging questions. Do we hold people living with dementia to a higher standard than we do ourselves? What do you and I do? We walk, we explore, we get our Fitbits and do our steps. And if we don't like the talk, we get bored and leave. But if people with dementia try to do any of those things, we say they're wandering, they're eloping, they're exit seeking. You and I get restless when we're forcing other people's rhythms. But if people with dementia do that, they are sundowning. I'm going to show you how to cure sundowning in a few minutes. We go to Costco or one of the big box stores and we shop in bulk. People with dementia take extra things for their room. They're considered hoarders. We get angry, sad, anxious, frustrated. These are normal human emotions, but you can't have normal human emotions. If you have dementia, it becomes a challenging behavior. And lastly, we don't like being locked up, bossed around, or touched by strangers. But if people with dementia do that, they are resistive, agitated, or even aggressive. So is dementia really the root cause of the person's actions? Now, there's no question dementia is real. And people have some very important struggles. And some of them I've got here: retrieving information and memories, communicating verbally, coping skills or maintaining social filters, and executive function, which is planning and problem-solving skills. So as a result, the changes of dementia might modify how a person responds to the situation. But that's different from saying the brain disease is the root cause. Very quick example I like to use, very simplistic, but we can then extend it to more complex situations. If I were to put you all in an activity now where if you were in a group, I said, okay, I'm going to pair you with the person next to you in this seminar, and I want you to go away to a shower room and your partner's going to strip you naked and give you a shower. I'm sure you'd all be jumping to do that. It's not an easy thing, and yet we ask our residents to do it pretty much every day, and sometimes with strangers who come in the room. But if you were to go through that, and if the person put you in the shower and the water was too cold, what would you and I do? You would probably say, the water's too cold, or we might even reach over and adjust it to our liking. We can do that. If a person is very challenged by dementia, cannot communicate that, cannot handle the stress of suddenly having cold water, they might scream or shout. They might even strike out at the person providing care. So dementia changed the way that the person responded. But did the dementia cause the distress? No, the distress was the cold shower. And if you think that this is a symptom of dementia, you might give a pill before the shower. You might try some non-pharmacologic approach like having soft music or a nice spa-like atmosphere and warm towels. But if you don't turn up the water temperature, you haven't solved the problem. And this is why just saying that these things are symptoms of dementia is not adequate if there is a deeper root cause. And I've come to believe that the root cause is almost always there. It is not simply due to dementia. What do words and actions represent then, if not dementia? Well, the biggest category, I think a lot of people call it unmet needs. I'm going to call it challenges to well-being. I think the problem with unmet needs as a term is that it's a little simplistic. It leads us to look for one thing, like, oh, they may have pain or they may need to go to the toilet. It's much more complex, as I will show you. There are sensory changes with aging, with dementia. And if you're not aware of how dementia affects the five senses, you may miss that. People may be communicating through different ways than they used to. They may simply be expressing agency in a situation where they feel they have little control or choice. It may be just a different way of interpreting the world and problem solving. I also look at that when I'm challenging our language around delusions, which we won't have time for unless you want to do in the Q&A. It could be a response to a physical or an interpersonal, relational aspect of the environment. And as we talked about, it could be a normal reaction. So there is no medication that's going to help any of these 7 categories. And there's no generic non-pharmacological approach that will help these either. We need to know the person. A few more examples just to challenge you. Trying to exit a living area is never abnormal. What's abnormal is locking the door and not letting people leave. If I had you in a seminar and somebody locked the doors, after a while, you would be upset and trying to leave too. It's not abnormal to walk through a door. Resisting being undressed by somebody you don't recognize is not abnormal. What would you and I do if someone came up to us and started removing our clothes? Wanting to do things your way, at your pace, and on your terms is not abnormal. And the last one, a bit of a challenge again. Being angry if you've expressed a concern to someone they tried to correct you, distract you, redirect you, or lie to you is not abnormal. If you expressed a concern to your manager, your coworker, your loved one, and they started talking about the latest Maple Leafs game to try to distract you or redirect you, would you feel like anybody cared about what your concern was? And that's why when we do that with people with dementia, it just comes back time after time because we're not hearing what they are saying. So I believe the last words are the antipsychotics and similar psychotropic drugs are largely ineffective and potentially dangerous. And really, when you think about it, people with dementia don't have too much dopamine. Dopamine blockade never really had a good biochemical rationale, especially in Lewy body dementia where you have dopamine depletion. But antipsychotics were not the real problem. That's why we're switching to other pills and we still have problems. The real problem is just the idea, as I said, that people who are in distress need a pill primarily. One more challenge before we get to solutions. And once again, why non-pharmacological interventions don't work. They tend to be generic laundry lists of things we try without knowing the person, without underlying meaning for the person, without being person-directed, tied into domains of well-being. They're often treated like doses of pills, hold laundry, QD, or PRN. When the person gets upset, give them a hand massage. But it's superimposed upon the usual care environment, the usual approach. And so it doesn't really get where it's going. I'm going to try to fit this story in because it's so powerful. It was powerful to me because I did all those things when I was trying to be non-pharmacological, and they never lasted very long. And I was back at the med cart. But I heard a story many years ago about a man who moved in the state of Iowa, which is kind of like Saskatchewan and Manitoba, a lot of farming out there. And he had Alzheimer's, could not express himself very well with words. And he kept trying to go out the back door into the backyard. And they didn't want him to go outside. The door was alarmed. And they kept trying to redirect him. And they tried a lot of different approaches. But the more they did that, the more insistent he became. So after a couple of days of struggling with him, the manager said, "It's a nice day out. We have a fence out there. Just stand back and let him go and let's see what he's doing." So he walked to the back fence, and there was a herd of cows in the pasture behind the fence. And he stood there and he watched the cows for about 15 minutes, turned around, walked inside, and he was calm all day. When they had their meeting with the family said, well, he was a farmer. He always checked on his herd, and he probably saw them out the window and wanted to check on them. Now, I'm not telling you that just because somebody came up with a clever way of solving one person's dilemma. I'm telling you because what do non-pharmacologic approaches tell us to do with a guy like this? Try a hand massage, try some music, maybe personalized music, try, aromatherapy. Those are all good things, but if he wants to check the cows, they are not going to work any better than pills. We have to know the person, and we have to train those approaches to things that actually fit into what is truly needed by that person. So I ask people to shift paradigms. If people seem distressed or are doing something you don't understand, what we're traditionally taught is that over 90% of people living with dementia will experience a BPSD during the course of their illness. You see this in journals, you see it in the media, you see it in education programs. So when you see that, where do you view the problem? Who's got the problem? And how useful are medications? Now, suppose instead we taught you that over 90% of people living with dementia, will find themselves in a situation in which their well-being is not adequately supported. Now, where does the problem lie? Now, how useful does a medication appear to solve this situation? It's a whole different way of thinking about the same problem, and it leads you down a very different road. That second big brain shift, using well-being as our main goal, once again, why do that? Well-being needs are universal, as I said, and people who are chronically ill or living with dementia have difficulty maintaining their own well-being. And not only are we not taught about supporting well-being in our professional training or family training, but many of our usual daily operations, like rotating care staff, actually erode people's well-being. So I believe that virtually all the distress I've seen that's been hard for people to solve has its root cause in the lack of usually several domains of well-being. And that's why I say it's more complex than just a simple unmet need. And this happens wherever people live because well-being is not adequately supported by very knowledgeable, caring people. It's something that's just not been on our radar. And it's something that my trainings really focus on because we know that people aren't getting it. The advantages of a well-being focus is proactive and strengths-based. It can be helpful regardless. You don't have to know what the person's diagnosis is, what their stage is, what their level of ability is. This works with everybody. And the biggest thing is it doesn't cure dementia. It doesn't make it go away. But what you're doing is you're providing resilience and reserve for people who live in a challenging life with chronic conditions like dementia. So it's like turning the heat down on the kettle. People who are lashing out are on the boil because their well-being is not supported. And when you start to fill those well-being glasses, you actually start to see people move away from that crisis point, and you don't see the kinds of reactions that you have been seeing. The third shift is being proactive and not reactive. This is not wait till someone gets upset and do something. This is find out what's missing and put it into their daily care plan and do it on good days and bad days, whether they're having a problem or not, because you're building reserve. You're not just trying to solve a problem in the moment. So it's not just reacting to the stress. It's a series of 24/7 supports built into the environment. Couple examples. I'll be real quick with this because we have a couple other things we want to talk about. Let's talk about identity. Part of identity is knowing personal rhythms. And it is very hard for a person living with dementia who's trying to make sense of the world to do this on our schedule for hours at a time. And when you are going at other people's schedule, you might need a rest, but there's an activity, there's a meal, there's something else happening. You might have wanted to sleep in, but you have to get up because breakfast is starting in a half hour. When you get to about 2 or 3 or 4 o'clock, it can be really exhausting. And that's the time when the sun gets lower and we blame it on some sort of a circadian rhythm. But the truth is, when I give my 2-day, 14-hour seminars, I make people sundown all the time because they work on all shifts. They work on their feet mostly. They're sitting at tables doing a limited amount of movement. And usually about 2 o'clock, we see sundowning in people without dementia. Beatitudes Campus in Phoenix recognized many years ago that they needed to remove triggers that were making people think they had to do something. So they told the staff not to leave visibly, not to make all this commotion around coming and going at the change of shift. And they also instituted a rest as needed policy. When someone's getting frazzled, doesn't matter what's going on or what time of day it is, they can disengage and they can rest. And they have basically not had sundowning for over 15 years now. At Schlegel Villages, we opened an enhanced support neighborhood during the pandemic. We had to try and de-stress and kind of, debulk some of the people waiting for placement in the hospital who had ended up in the hospital for various reasons, COVID, injuries, illness. But because of their dementia, because of how stressful the toxic the environment was, they were medicated, they were restrained, and no long-term care would take them because they didn't look like the kind of person they wanted to take. So Schlegel opened up an empty assisted living neighborhood that had 20 private rooms and said, we will take people, we'll give them enhanced support to get them out of the hospital, and we will give them really careful support and try to get them back to a place where they are more independent and can move to another level of care or to traditional long-term care. One of the things they did, besides having a somewhat increased staff to resident ratio, was they had 12-hour shifts, 7 a.m., 7 p.m. And when I went to tour them after they've been open for several months and they were doing very well, I said, well, when you were ready for this, what bothered you the most? What did you fear the most? And they said, what we fear the most is sundowning. And I said, well, what's happened since people moved in? And they said, it doesn't happen. And it occurred to me, in most places that work 7 to 3, 3 to 11, what's going on in the afternoon? People are getting ready to sign over. They're doing their tasks. They're creating commotion. New people are coming in. There's sign over. When you work 7 to 7, what's happening at 2 o'clock? People are just hanging out. They have nowhere to go for 5 more hours. And they were engaging with the residents. They were doing things differently. It occurred to me that 12-hour shifts could be a powerful antidote to this so-called sundowning, simply by changing the way we work and helping people to be relaxed at a time when they need a quiet environment. I said I'd talk a little bit about communication. I'll give it about 5 minutes and just give you a few things. We could talk an hour about that, but communication skills are not only important for connectedness, but they're important for autonomy too. They are probably the first level of empowerment is knowing how to communicate well, knowing how to listen well. So a couple things, and you probably see some of these posts on LinkedIn about this too. When you go to see somebody living with dementia in a hospital or in a long-term care home, wherever you're visiting them, I always tell people, first of all, to clear your brain before you walk into their room. Clear your brain because we are used to multitasking. We are used to thinking about what we just did and what we're going to do next. And people with dementia need our 100% presence and attention. And if our mind is not on the conversation, people with dementia can sense that. And someone who has trouble communicating, it can be enough to make them shut down. So I try to get people to just take a deep breath, center themselves. When we say, when you go to someone's room, we always say knock and ask permission to enter. That enhances both security and autonomy for the person, respecting their private space, and not only asking permission, but waiting for the reply before you go barging in and walking up to the bedside. And the last thing about that is often we will identify ourselves. We'll say, hi, it's Al, I'm your nurse, I've got your medications. Or hi, it's Al, I'm your PSW, I'm here to help you with a shower. And we say it very nicely and we ask permission, but every time we do that, we announce what the task is going to be. And if you put yourself in the place of the person lying in the bed, sitting in the chair, the message that comes across is, I have no control over what's about to happen. You're telling me what's going to happen next. Where's my autonomy? So what I suggest people do is knock on the door, identify themselves, and say, can I come in and visit with you for a moment? And have people come in and visit with them for a moment, connect with them. And then when you've got a good connection, you can then introduce what you had come to do and see if they are okay with doing that. It's a whole different way of doing it. But when people are seen as being resistive, that little thing can make a huge difference. The other thing that makes a huge difference is sit down, get down to eye level. And I know, once again, when we're on our feet all day and rushing around, it seems like a waste of time, but it is time well spent. Just finding a chair, or asking permission to sit on the edge of the bed or the windowsill, get down to the person's eye level. 3 reasons. First one is when you're face to face with a person, they can see you better, they can hear you better, they can see your expressions, see your lips move. It's better communication. They don't have to, if they're arthritic, they don't have to look up at you, which could be uncomfortable. The second reason to sit down is when you stand over a person, there's an unspoken dynamic of control, who's in charge. And particularly, once again, if people have issues with choice and control, you don't want to be over them. You want to be at their eye level or even somewhat below their eye level, give them a more superior position. The third reason to sit down is there's another unspoken message, and that is, I have time for you. If you sit down, relax, the person knows you're not about to run away to another task, and they can find their thoughts, they can take time to process, and they can feel much more relaxed. And you and I know from having angry conversations on the phone and thinking 5 minutes after we hung up what we should have said, whenever we're stressed, it's harder to find the words. When you help create an environment where people can feel relaxed, feel at home, and feel not rushed, you will get better results. One other tip I'll give you, there's many more, but another one is what I call speaking like a sports interviewer. Sports interviewers are kind of funny because they never ask questions, you know? So if the Maple Leafs lose a hockey game, they might come up to the coach and they say, well, coach, you had a rally there in the third period, but you came up a little bit short. And they hold the microphone out, but they didn't ask a question. And I always used to think that was kind of funny, but it's always done in sports. And I realized that when people are forgetful, that's a perfect way to talk with them, because when you ask questions, you're asking for information. And information has to be remembered, and it might be correct or incorrect, and it can put people on the spot. And so instead of asking for information, make a statement. And then the person can answer any way they want with any degree of detail they want. If you say, what did you have for dinner last night? Ooh, memory. If you say, I heard they had lasagna, that must have been delicious. Then they can say, yes, it was. They can say, no, I had chicken. They can say, I like lasagna. They can say, we used to make sauce at our house on Sunday. They can say whatever they want because they don't have to be right or wrong. So if your questions are not being answered, try using statements. Secondly, you can also try using questions that ask for opinions, because your opinions are always right. They're your own. So instead of saying, where did you live? Say, tell me about your house, or what did you like best about your house? And you might get some clues as to what well-being needs are not being expressed. I have my colleague Danielle Greenwood up here because she has the best consistent staffing model I've ever seen in the world. She's from Australia. And just very quickly, because I want to talk about the hospital before we wrap up, she started with her former organization, Our Care, about 36 communities, one at a time, going to a consistent staffing model where the same people care for the same people every day, all the time. There was no rotation every 2 weeks or every 2 months. And just that's all they did. There was no, antipsychotic initiative. There was no special falls initiative. All they did was put the same people with the same people. And I just want to show you with the first house that they reported on what they saw. First of all, they cut down the number of staff in one area, which is great when you're forgetful. And the number of people that actually were providing personal care to a resident over a month went from 28 different people to 5 different people. Huge difference when it comes to personal care. But look what happened besides the connections and the relationships. Big decrease in chest infections, almost complete elimination of pressure injuries, big reductions in skin tears, reduction in falls, 3-kilogram average weight gain, and a huge reduction in PR and psychotropic medications without really focusing on that. They had a elimination of formal complaints from families. Doesn't mean families were happy all the time, but they had a relationship with the care team. And when they had a concern, they went straight to them. They weren't kicking it to the formal complaint process anymore. On and on. Look at sick leave, staff turnover. If I went to a long-term care organization and said, I can reduce your staff turnover by 50%, they say, what can we do? And I'd say, well, you have to stop rotating staff. Oh, gee, I don't know. That's hard. Well, look at the numbers. Look at the job satisfaction. for nurses and PSWs. Huge. And all they did was create relationships, connectedness. So connectedness sounds fuzzy, but consistent assignments are not fuzzy at all. And this is how you change operations to make those well-being domains stick. So quickly from this, I developed a case conference approach. And once again, you can look at those 7 domains as 7 drinking glasses. And I have seminars where people will bring in a challenging case. I've done this in a dozen countries on 5 continents, more than that now. And they bring in a challenging case, and we break people up into those 7 domains. And each group works on a domain. And we say, based on what you've heard, how full is this person's glass right now? How much of a sense of identity do they have? How much security? How much autonomy? And the amazing thing is that with these really knowledgeable, caring people who've done everything they've been taught, it's rare to find one glass more than 30% full, and most of them are nearly empty. So I can say, you've done everything that traditional education has taught you. Here are 7 life-giving areas of human need that our system does nothing for. So why are you shocked that this person still is not better? When to use it? When the other simple solutions haven't been found, and whenever you're stuck or frustrated or about to use medications. So we look at those drinking glasses and we draw a corresponding level. I like the visual so you can see how empty those glasses are. And then the hard part, and that is to stop trying to fix the behavior and just proactively 24/7 build a well-being plan. Pick one of those empty glasses and build a plan for autonomy. It's going to be with every interaction. How do we increase this person's autonomy with every interaction, with every event of the day? How do we build their security? And you can add more glasses over time, but sometimes it's best to stay with one. My colleague, Professor Jennifer Carson, put this approach on steroids by coming up with a team huddle-based version. So when a care plan meeting only has some shifts and takes too long, in 5-minute stand-ups on every shift, you can break this process into 4 different huddles. Groups of huddles, assess their well-being, talk about what's working well, start the well-being plan, revise it, and then take action. And then a few weeks down the road, you can reflect on it and make adjustments or maybe add another well-being domain. So can this really replace medications? Well, I did a QI study last year at the village of Aspen Lake in Windsor, Ontario. 132-person secured dementia neighborhood. Nothing outrageously new about it. It has long hallways. It has lots of double rooms. It has a locked door. And I asked the team to use this approach with 1 person per month. And if they had time to pick up other people along the way, to do that as well. And we were going to do it for a year, and they were going to commit to that. And we did monthly coaching calls too, because it's counterintuitive. It takes some practice. So they ended up using it with 20 people during the year. One of them had a psychiatric illness that they were on medication for. The other 19 had dementia without a psychiatric illness. And all 19 of them stopped their antipsychotic over the course of the year with this approach. Now, 6 months down the road, one went to the hospital and the hospital restarted one. Another one, the family wanted it because the person got upset one day and they just didn't like the idea of them not being on a pill. But the other 90% were still doing well at that point in time, which is still a pretty remarkable number. There was also, we measured qualitatively and somewhat quantitatively, improved staff and family satisfaction and decreased staff burnout. And I now have, as I mentioned, a knowledge mobilization grant and creating toolkits for both professional and family care partners. Now, I have a friend named Dr. Angela Norman. She's a doctor of nursing practice who's been using my approach for 10 years now, almost, in the state of Arkansas. And she's now using it with 47% of all the homes in Arkansas. She is a consultant. She's doing instructional seminars on the well-being approach, in-home coaching. They use it proactively in care plans and in case conferences, and they have a hotline for challenging situations. She has found, as of January, when I last talked to her, across 105 long-term care homes, they're averaging 4.5% in antipsychotics, a fourth or a fifth of the U.S. average. Once again, this is nearly half the homes in the state. So if you talk about being reproducible, that's a pretty amazing number. There was no increase during the pandemic, and their ranking in the antipsychotic use improved from almost last in the nation to 7th best. And once again, I think her initiative had a lot to do with that because she's working with so many homes. And they also, in the first year, cut down their Form 1 discharges to jury psych units by nearly 3/4 in the first year. So quickly, the acute care conundrum. I'll just take 3 minutes because I want to have lots of Q&A. I have something I call Power's first law of geriatrics, which is a hospital is no place for sick people. The corollary is you better be pretty healthy if you want to survive a hospitalization. It's a tough environment. It's really tough for older people, and it's really, really tough for people living with dementia. They're acutely ill, they may be delirious or in significant physical or emotional distress. The surroundings are unfamiliar, the staff are unfamiliar, and vice versa. And the care systems are even more regimented and institutional than they are in long-term care. So where does this triangle, this pyramid fit in? How can we possibly do anything? Well, I haven't been working in acute care for some time. I'm not the experts, many of you are, but I know you're on the call and may have feedback on this, but I'll just tell you from my experience what some of my thoughts have been. You may be doing many of these things, although from what I've heard about transitions between hospitals, I think a lot of these are still being missed. And a lot of it's just the hospital system, hospital priorities. It's a tough thing to get the people with dementia that have a hip fracture or pneumonia to be high on the visibility of all the different things hospitals have to keep their eyes on. But just a few medical nursing basics. I just have a couple slides to finish up with. First of all, minimize medications. Avoid those. You know, we used to have residents who come in when somebody was admitted, they just write a PRN for everything that could possibly be needed so that they wouldn't get called at night. And that's just dangerous when it comes to somebody with dementia. Minimize medications. Don't use two when one will do. And dose medications appropriately. Start low, go slow. I'm sure that Tricia and other geriatricians who are on the call will use that mantra over and over again. Avoid anything with anticholinergic and psychotropic properties unless absolutely necessary. Remember that antipsychotics are very anticholinergic. And we had a rule at my long-term care home, by the way. We did not use PRN antipsychotics. We said, this is not a good idea. You should either, if you really think someone needs it, write a standing dose, don't use PRNs. And I'll give you 3 reasons very quickly. Number 1, usually by the time that drug gets to the person and gets in there, whatever upset them has been calmed down, and what's the drug doing at that point? Number 2, I think it's a block to critical thinking about the cause of the person's distress. When we know we have a pill we can just give, we stop asking, why is this person upset? And number 3, the risk-benefit analysis for antipsychotics is bad, whether they're given PRN or standing dose. Maximize day-night cues. Make it quiet and dark at night. Make it active during the day. And think about noise. I was just talking about the 4-bedded rooms that you have in some places of the hospital. And just be aware of the sounds that we make in our normal work environment. And think about how those are perceived by people that are stuck in that bed 24/7 and cannot punch out and go home. Don't do unnecessary vital signs or other visits. If a person doesn't need Q2-hour blood pressures, don't do it. Discontinuing all those tubes, line wires, catheters as soon as is possible. Assist them with meals. I can't tell you the number of times I walked into hospitals and saw a person who was very affected by their dementia sitting there with a tray with nothing open for them, not eating because they can't do anything. And then the tray gets taken away and they're written down as having had poor PO intake. Getting people out of bed regularly, assisting with a regular toilet schedule, and adjusting the call system. Not everybody can use the call bell properly. And when possible, for people at the greatest risk of distress, try to give them a quiet, private environment if you can. Now, beyond that, some operational transformation, consistent assignments as far as possible. I know how crazy it is staffing in the hospital as well as long-term care, but the people that need it most should have it the most. Optimize your communication skills, as I talked about. And I'm putting the phrase here, orient, don't reorient. It's great to tell people what day it is and what's going on, but if people say something that doesn't match your reality, trying to tell them they're wrong is usually a dead end and may cause more distress. So validate people's feelings, understand them, listen to them. You can open the conversation by telling them what day it is or what time of day it is, but don't try to correct people that are holding on to something that doesn't make sense to you. Minimize room moves. I like what I call lazy Susan approach. Instead of sending people to all these different departments, let them stay there and rotate everything around to them. Let people come to them so that they don't have to be uprooted and moved to different places. Give people access to sunlight. I love that St. Peter's has this outdoor area. Get those people outdoors. I'd be out there every day if I were in the hospital and had the ability. A top 10 information sheet about people's personal information. Not medical information that's not legal, but personal information, so that people who come in the room know something about them and can talk about those things. I know that there's a help program now in Ontario where we're bringing volunteers in to engage people when staff don't have time. Keeping up with those kinds of things would be great. Try to maximize the feeling of autonomy and security with every encounter. Go deep into systems and patient flow. This is something I've tried with a couple of hospitals. No one's been willing to bring me in to do this yet. And it's tough because, like I said, they have other priorities. They're doing, bypass surgery and everything else. But I think just like with long-term care, operations are the key. If we've been taught about dementia, we've been taught about delirium, we need to look at the patient flow. We need to look at what environmental services does for their job. What does catering do for their job? What do PSWs do or nurses? And think about, is this person-centered? Is this really helping the person with dementia? Or can we shift our operations to be better for them? And the bottom line, as soon as any other living environment can provide adequate care, get them out of the hospital. Because as great as you are for people acutely ill, it's a bad place for someone to be for any amount of time longer than they should be. I'm going to wrap up there. Sorry about the slide problems at the beginning. I went over a little bit, but I think we still have some time for discussion. So I'm going to turn it back to Bahar. And thank you again very much, everybody, for being part of this. I know there's over 200 people registered, and I really appreciate your attention.
Wow, thank you so much, Dr. Power. That was incredibly thoughtful and inspiring and eye-opening, to be quite honest with you. As always, you have given me a lot to reflect on. You always do, not just about dementia itself, but about how we show up in relationship, in care, and in the community with those living with it. And I'm sure all of our participants are also inspired by your presentation, seeing clearly why we need to transform the way we support those living with dementia. We're now going to shift into the question and answer portion of our session. If you haven't already, feel free to type your questions in the question and answer box at the bottom of your screen. We'll do our best to go through as many as we can in the time we have. So let's dive into the conversation. So there are a couple of questions already, Dr. Power. One is regarding the copy of your slides. Do we have the permission to share that with the participants?
Absolutely, absolutely. And it might
Wonderful.
be easiest for everybody just to put them on a PDF or something so they have a handout or something like that.
That's wonderful.
Yeah.
Thank you for that.
And I'll let you do that. If there's something wrong with my PDF maker, the slides come out too small. So I'll leave it to you to do that.
We'll take care of that. Thank you so much, Dr. Power. Also, there was another question about the recording of this webinar, and we will be sharing that on the YouTube channel of the Obgeris. So that will be available to everyone as well. We do have another question from Haley Marie. Is there any standardized well-being assessment that you would recommend?
What a beautiful question, because I was just talking about that yesterday with my colleague, Dr. Laura Middleton over at the RIA. I don't believe that there are a lot of great well-being assessments. I actually was part of creating an assessment for that Eden scale about 15, 16 years ago. We came up with the original questions, sent to the University of Utah, who did some validation, and they brought the Likert scale down so that more people with dementia could answer it. Now looking back 15 years, I think those questions need to be evolved. I think some of them are not really capturing what we need to capture. And I was talking to my colleagues, Dr. Carrie McCaney and Dr. Laura Middleton, recently, who are our dementia research chairs, because they also are frustrated with the lack of good scales that measure well-being. Most of them are medicalized, they're based on functional ability, or they're these horrible things, that only look at, behaviors and negative things. And they happen to mention that we were thinking about trying to come up with our own well-being scale, working on that this summer. I said, sign me up. So the three of us are going to be convening sometime this summer and starting a project to create a well-being scale. And so I will keep you posted. There are some out there. I think we can do better, particularly for this type of approach. I think we can do better.
That's wonderful. Thank you for that, Dr. Power. We do have another question. What are the steps we need to take to shift from responsive behaviors to well-being?
I say, let's get rid of the word behavior. Now, the word behavior is not a good or bad thing. If I go to the refrigerator because I'm hungry, that's a behavior. But in the setting of dementia, it has become a pejorative type of term. And it is hard to take the focus off the person, even when we use that word, even when we color it with responsive behaviors or behaviors that distress or some of the things other people say. It just brings us back to that person. We got to manage that person. Managing is all about control. It's all about changing them and not us. And that's why I like well-being, because it's positive, it is strengths-based, it is something that people can attain with our help. And it's all about that different ability mindset. It's about creating accommodations us changing because we have more ability to change than the person living with the changing brain. So if we do that, we don't ask the person to walk up the steps. We build a ramp. That's a little bit of effort on our part, but it makes it easier for that person to engage with the world. A little bit of effort to change our staffing model or to let people sleep in. But the difference in people's mood, the difference in their experience of the day is so huge that it is worth every bit of effort.
And we agree. Dr. Power, next question is, do you have any tips on when clients with diagnosis want to leave or go home? What's the best way to help them with this when they cannot go home yet?
Yeah. Are you talking about any environment? Are you like long-term care, hospital? Does it say?
I would say that let's talk about hospital in this.
Okay, it's slightly different. In the hospital, I think because they're there for an acute problem, I would say, your medical condition is, I know you miss your home, but your medical condition is such that you need to stay here a little bit longer. But whenever anyone's expressing that, particularly when people are living in long-term care, but they're saying, I want to go home, the thing that doesn't work is saying, this is your home now. The person has just said to you that whatever this place is, it doesn't feel right to me. It doesn't feel safe. It doesn't feel nurturing. So to tell them this is where you're going to stay never makes people feel better. And I think the big thing, and this is a concept I want to take a moment on. Christine Bryden, who's lived with dementia now for, believe it or not, 30 years, wrote in one of her books that she believes people with dementia are making an important journey from logic into emotion and maybe more into spirit at the end of their lives. And many people are in the area where they're expressing themselves not so much in facts as they are in underlying feelings and symbolic thinking. So if someone says, I want to go home, they may not be thinking of the place at 35 Maple Street with the rose garden and the green shutters. They may be thinking of the attributes at home, which are often in those domains of well-being. So the first thing we always do is validation. Validate the person's distress without judgment. Don't try to talk them out of feeling the way they do, but really let them sit with that. Let them be emotional about that and say, it must be really hard. I understand how difficult this is for you. And then once again, by asking those non-directive questions, tell me about your home. Tell me about what you like best. You may get clues as to what's the underlying feelings, the underlying well-being attributes that are not being met in your environment. And you can't bring that home back. You can't bring that dead relative back, but you can bring some of those well-being aspects that are missing in that person's life, and often can address things better that way than by trying to talk about the facts of the matter, because they're not in facts as much as they are in feelings.
Thank you so much for that, Dr. Power. Would you say it's similar in a day program?
Yes, I think so too. And once again, a day program is a temporary situation. So the reinforcing the continuity is great. Your loved one, your partner is coming at 3 o'clock, pointing to the clock and saying, and then you'll be back home again. And then when they leave, saying, I'll see you tomorrow at noon. And then when the loved one drops them off, the loved one can say, okay, I'll be back in 3 hours. And they may not remember that, but you do it over and over again. It does start to sink in. It starts to be remembered, starts to be felt, even if it's not remembered. And the other thing is what happens in the day program. And the day programs need to have meaningful engagement. They can't just be entertainment or, I hate to use the term, but sitting, babysitting. They really have to provide all those domains of well-being. If you are just doing things for people and not with them, if they're not running, if they're not deciding what the activities should be, having active input, then it's not going to feel like a space where they want to be. So I want to go home also could be a sign of, this isn't meaningful. I'm bored. I don't feel like I'm in control of the situation. Look at those well-being domains. I can't tell you how many times diving into those domains of well-being and making the activity bring those domains into practice. So we're going to have a tea and biscuits. How do we bring autonomy into that? How do we bring meaning into that? How do we bring connectedness into that? And when you enhance those routines and make them rituals, then they become places where people want to be.
That's wonderful, Dr. Power. We only have 2 minutes left. I'm going to ask a couple of other questions from you. Any thoughts on potential technologies that can enhance well-being of people living with dementia?
I think there are. I don't want to go too much into this because time is short. But I think that, and I'm going to go with my good friend Bill Thomas, who was co-founder of the Eden Alternative. He said something I think really important. He said, technology is great to help with tasks. People are great for relationships. So I don't like the idea of technology replacing relationships. But if technology helps people to engage with the world, like something, technology based, some of the things like It's Never Too Late and other computer-based programs for people to engage with dementia, if it helps staff, AI or other techniques help staff get their job done so they can spend more time with people, it's great. I'm not crazy about the idea of, mechanical dolls who are supposed to provide companionship, because I'm not sure that, there's a lot of skill to communicating with people with dementia, to understanding them, to validating, to understanding the symbolism behind their words. That's a people skill. And I think we still need to, sometimes I worry that we make life easier for the care staff, but they still don't go to the bedside. They just find other tasks to do, because the mentality is still not, this person is my job too. And being with this person in any way they need is a really important part of the job. And we have to, our leaders have to recognize that and have to support that aspect of work.
Thank you for that, Dr. Power. We're right at 2 o'clock. There are so many wonderful questions in the question and
Send them on
answer
over.
box. If you don't mind,
Yeah.
with the team, if we can capture all of those questions that they're left unanswered and we answer them, and then we include them when we share the slides with the participants, I think it would be very meaningful for everyone.
Yeah, my life gets busy for a couple of weeks, but I will get to them all. I'll send them all back to you in a big email, and then you can attach them whenever I'm able to do it.
Thank you so much, Dr.
Sure.
Power,
Thank
for
you
a
all.
very
Thank you,
inspiring
Bahar, for the questions.
presentation. And thank you for all the participants for your engagement and your question. And we'll be connecting with you shortly with the slides and the answer to the questions that you have asked. I hope you have a wonderful rest of the day, everyone. Thank
Thanks,
you.
everybody.